No, please. Let's not go.
Did he approach from endoscope or he has opened?
No, opened.
Open.
The question was, how did you approach the maxilla? He opened it.
Okay, so we'll keep this as interesting and short as possible because because a lot of things have been discussed. So let's keep it simple. So we had shown, you showed the striker screwdriver, right? So you have 3 different companies. Just to give you an idea, you have your Synthes, which is called as the 90-degree screwdriver. Then you have the Angulus by K.L.S. Martin, and then you have the right angle screwdriver from Striker. Okay. So you have used the striker, right?
I have used striker and Synthes.
Okay.
Pretty much it's the same.
It's more or less the same. Yes, the concept remains the same. It's just that what you're comfortable with. Okay. I'm sure everybody knows why endoscopic assisted procedure, because you don't want a scar, the recovery is faster, etc. Is there anything else that you want to say which is not there? Abhi sir? Anybody? Ma'am? Is there anything that you want to add apart from the scar? Is the recovery faster?
Recovery is very quick.
Is very quick.
As compared to extraoral, recovery is very quick. Next day morning, they are pretty much it's more like a third mode of surgery incision now. Yes, they are going to have some amount of edema in the joint space, but still they are very comfortable. Recovery is pretty quick.
Fine. And do you always prefer endoscopic fixation?
No, not always. Anything above the level of, until the level of neck is okay.
Okay.
Condylar neck fractures under the level of condylar neck. Neck is also difficult, but it's okay, but still you can plate it. Anything above the neck, try straight away go for extraoral. Don't waste time.
Okay, so when you position the patient, do you keep a shoulder roll or do you do not keep it? I mean,
No, normally.
no. So do you place it or not?
No.
You don't place it. Yes. See, because when you place a shoulder roll, it goes even more posterior. So to actually reach the condyle, it gets more difficult. So no shoulder roll for patient positioning. So when you manipulate, does this happen to you often?
Yes, if you keep, giving, particularly when you are trying to drill, because now you have reduced, it stays in a proper place, but when you try to drill, there's nothing stopping it from the other side, there's no counter. So when you give too much of force, it can get displaced medially, but laterally displaced ones don't trouble us much. Still we can pull it out and get it over.
Yeah, so if it is a clean cut, there is a chance that it may get displaced. If there is an overlap, lateral overlap of the fracture, then it can get stopped. It does not get pushed medially when the screws are placed or when the drill is made. So
another thing which I want to add is, if you are putting a lot of pressure while manipulating or alignment, and if there's a bilateral condyle fracture where the other side is not grossly displaced, it might get displaced if there is unjudicious force is used, and that's one of the reasons why if there's a symphysis fracture or angle fracture associated with that, I do it at the end after reducing it, so that there is no undue pressure generated on the other side where the condyle is medially displaced.
okay, when you please.
Do you have any equipment to give a countdown to the screw?
Yes.
You can
Yes,
place
yes, we do. Like as I said, usually what I do is I try a curved, basically it's a periosteal elevator, but curved like an S shape. So I go through the sigmoid notch and just give a counter pressure so that it doesn't slip on the lateral side. Another thing which I do is without the plate, I choose the location where I'll put the place. It's a guesswork, and make the screw hole without the plate, and then take the plate and fix it there. So once you have, as you mentioned, that 80% job is done, once your first plate on screw is secured, most of your job is done, because you can manipulate. And for manipulation, at times I tend to make small holes in the condylar head if it is possible, and maybe use, as I said, a modified skin hook to grab it and pull it to position.
Okay, so has there been any situation wherein you had to abandon the procedure and you had to go for a
A
facial?
lot of times, as I mentioned,
So you do take a consent?
I do take a consent. I do explain it to them that this is relatively new and there can be complications because, as you mentioned, your staff are not very supportive when you take a long time. Like as you mentioned, my first case took almost 6.5 hours. But as we kept working and all your team members get oriented, provided you are working with the same team, definitely the time is going to reduce over a period of time.
Okay.
So
this
consent is a must. I mean, as I said, the last case which I showed all the complications I got sick because he went to other surgeons, senior, mid-level. Siddharth knows about this case very well. So his colleague kind of saved me, and a very senior surgeon, I don't want to name, he said that, why address bilateral condyle? We could have managed with Ashbars and elastics. Yes, we could have. And while doing an open surgery, I managed to damage the frontally. So patient was not able to even. So he said that your facial nerve is gone, although the facial nerve was not gone. And I kept communicating with the patient. So I think that is the most important thing. Once something happens like that, we tend to push them away. I would request not to do that. Keep constantly be in touch, gain their confidence, keep talking to them, and try and assure them things will improve. So I think that's the only way out, and complications will happen once you start these cases. So you have to be ready for it.
So this is our personal experience. This was a patient with a bilateral condylar fracture. We tried endoscopic. We couldn't because you see the amount of soft tissue that is there lateral. It was very difficult to retract, put the scope, fix the condyle, and then we had to go externally and fix it. So if you have any patient who has so much of soft tissue bulk, better not to try endoscope. It is better that you go with facial incisions. How do you stabilize the segment? Do you put the plate first and then you hold it, or how do you do it?
Yeah. So when you use this, particularly with the striker handpiece, there is a plate holder which is very handy. So you take the first screw goes along with the plate. So once you go and secure the first screw, there is a plate already there with which you can handle the instrument, handle the fractured condyle. And the other way of also stabilizing the fractured condyle is using the clockwise and counterclockwise instrument. You can hold with that and then also try to pass the screw. So that's how we stabilize it.
Okay. And choice of plate, trapezoidal or straight plates, or?
I would prefer the trapezoidal and the reinforced straight plate by striker. As I mentioned earlier, it's just 4 holes and I'm done.
Right.
See, if I have to put 2 plates, see the number of holes you can count.
Exactly.
So there are more chances that it might not engage the bone, might go into the soft tissue, and you'll have to realign. And realigning the plate, making new holes becomes, because the space itself is very less.
Small. So how do you pre-bend it? I mean, do you go back and
So
forth?
I actually, it's not that always I pre-bend. Sometimes it is needed. Yes, I do go back and forth. But the most important thing is once I've secured the first screw, I see how much I need to bend.
Okay.
Okay. So once the second screw is there, the rest will automatically fall in place. And as he showed his last case, try and get bicortical anchorage. That would be gives more stability, no doubt. So that's about it.
Right. So there's one thing that we do in our unit. If you have a condylar fracture and if you have access to VSP, what we do is we reduce the condyle beforehand, and we reduce the condyle and we print a model. Reduce it and print a model so that you can bend the plate on it. You don't have to go back and forth. So you know exactly how the plate should fit or should be bent, and that can save time. And the moment you go back and forth, it is tedious. It gets irritating. Yeah, we have an in-house printer. So what we do is we print a model and we bend the plate on table and use the same plate directly inside the patient, so that you don't have to waste time in plate bending and going back and forth. Okay, so have you ever done a bilateral condyle endoscopy? Yeah, you have mentioned it. What about you?
Yes, I have one case of bilateral condyle, but both were low of condyle.
Like I have done most of the cases on bilateral condyle, but I was not addressing both the sides. All this while I was addressing one side. Once it got the occlusion, I was okay with it, and maybe with cross elastics I would correct if there is any mild deviation. But this was one case where I had addressed both the sides. So one side, if you have done, I think that's okay if the other side is not grossly displaced. So if there is displacement, then more than what is mentioned, then you can address both the sides, but then it increases the time also. Addressing both the sides becomes quite difficult and time taking. Okay. And another thing which I do, as she was asking how do I stabilize, you can also just lodge and screw arbitrarily in a position and hold that screw with artery forceps and manipulate the condyle area.
Okay. You said you don't have access to 90-degree screwdriver.
No,
right? But you have access to trocar. Yes, of course. Would you try it?
Maybe if I didn't have a 90-degree screwdriver, I would have
No.
attempted. But
For example, you have both. Would you try trocar?
When I would try is sometimes the top screw, the second
Topmost.
screw on the proximal end. If it is going to get extremely difficult, my retraction is not sufficient,
Correct.
then maybe I think instead of placing an incision, I can go for a trocar.
Another thing is, see, when with the trocar, you can also hold the plate. You can put it in the screw hole and move. So you have, say, supposedly the proximal segment you have one screw and the distal segment you have placed one screw, but you see that the proximal segment, the distal hole, is not engaging in the hole. So you can put the trocar in the distal segment, second hole, and try and manipulate. So once you move, it moves the whole thing.
Any question from the crowd? Anybody, any question with regard to endoscopic? Please.
Thanks, guys. Endoscopic condyles, steep learning curve, it's vertical, yeah, it's a vertical, it's not a curve. I tried them many years ago. A couple of things I found. You guys are all used to looking at your hands when you're operating it. You're looking at a screen. So that's a very difficult concept to grasp, is to look at a screen while you're operating, unless you do a lot of microvascular stuff down a microscope and stuff like that. For me it was quite easy because I'd done an ENT job, so I was quite used to using scopes, and I did a bit of training in laparoscopic surgery as well. The biggest thing I found with this is creation of the optical window. You need to get good retraction in there so you can see, yeah? When I first started doing it, it was a company called Medartis. They were the first ones that came out with this kit basically, and then synthesis. And they actually had some beautiful retractors. They were fibre optic retractors. So you can actually had a retractor that went up behind the ramus and illuminated the whole area. And it was a fantastic thing as well. So you actually, it's creating of the optical window. Also as well, another little technique about access is, remember yesterday, I think I said yesterday, don't touch the periosteum. Sometimes you can't get that bit of extension. Then score the periosteum. Yeah, make a little nick in the periosteum, and that'll just release the tissues a little bit, so it gives you a little bit more laxity, basically, to get your instrument in. Particularly if you're doing what Gary Ravin said, is you're using a right-angle screwdriver. You've got a right-angle screwdriver in there, you've got your optical instrument in there, you've got a sucker in there, you've got everything in there, and trying to get them all in there is very, very difficult. It is a steep learning curve. As the guy said, please do the open procedure first of all. Do what Sonal's talked about. Make sure you can do that, because that gets you out of jail then, yeah? So make sure you can do that. Then you can think about doing endoscopically assisted condyles. I don't do them anymore, sorry. I abandoned it about 10 years ago when my first one took me 4.5 hours. I was cursing, swearing, and that's where all my hair was lost, basically.
Just to add on what Dr. Andrew said, in Synthes there's a retractor into which you place it into the optical cavity, and then you can have the scope go through that. So it acts as both. So you can retract and you can have the scope also in that. So you don't have to hold it separately. So it's a single unit thing that can be done. Any compression bandage or drain that you would place?
I use a drain.
I saw it in your presentation.
Extraoral incision which I placed to introduce the trocar cannula, I use that as a drain. drain tend to reduce the swelling much faster. Initially I wasn't doing it, so there would be quite a bit of swelling because we tend to strip the entire masseter of the mandible. So there is swelling, and it takes some time and pretty much visible swelling. So with the drain, the recovery is, I guess, much faster. You can use a vacuum drain that aids in it.
Okay. Any facial nerve injury, sinus-seal?
No.
Okay. And do you place them
We
with
had a
IMF
temporary
or?
weakness.
Pardon? Weakness.
One patient we had temporary weakness, but I think that's because of too much of retraction for the patient.
Okay. And post-op, you put the patients on
I-
IMF or do you
No.
leave them?
Till date, I didn't have to.
Okay.
Only thing, as I said, that if I see that if there is any deviation, then maybe I'll put a cross elastic using those orthodontic bands. That's it. And the one which I mentioned, I had facial nerve injury, but both the cases where I had, one case I had facial nerve injury, that was because I did the open method to take out the implants. As I said, the patient was having pseudomonas infection. And the other case, I would suggest not to use regular plates and screws when you are thinking of reducing condyle, because some of the brands that we use, because of the cost, might not be of that good quality, and screw loosening becomes a problem. When I placed it, the screws were fine, but the patient developed a persistent fistula. I thought initially it was a salivary fistula, but there was a loose screw. It was in the tract, the fistula's tract, so it was easy. And always, re-exploration is very difficult in condylar fractures. If you have done it endoscopically, re-exploration, you should always be ready to do an open procedure if it needs a re-exploration.
Okay, so that brings us to the end of this talk. Thank you so much. Thank you, Dr. Katir.
Thank you. Thank you, Samana. Thank you, Francis. Thank you so much.
And this is the last discussion on TMJ. Any questions?
I think it's a chocolate time. Yeah, we'll have to do that.
I think everybody is through with all the approaches. I mean, mostly I'll keep our discussions and questions to later to the approaches only. Yeah, 10. Well, wind up as ASAP. 10 square, man.
Any questions before he starts? Approaches.
I wanted to ask, like they have done an endoscopic reduction of the condyle on one side, and other side he said that it's okay to leave it like that. So post-operatively, how many days of box elastics and IMF? Yes. Yeah, see, again, this is a question of whether you open both sides or you don't. Come next year, I'll tell you.